I wanted to talk to you about something that interests all of us and that very few of us realize. We live in interesting times, very interesting times. I read in the news this morning that we car owners should be aware that the car constructors in a secretive way collect data, our driving data. They register when we turn on a CD, when we brake, when we speed, when we fuel up, and when we do the maintenance of our car. If someone looks at my LinkedIn account, I immediately receive a warning that someone is getting into my account, and I know who's looking at my account, who's peeping in. But when someone wants to view my medical file, under the current regulation, I do not have any ability to block, to view, or to control whoever checks my data. And this I find both troubling and perplexing. Our government has begun a campaign, a goodwill campaign, to promote the exchange of the electronic medical data file, the EMD. And now that it is clear that the patient, and in extension his GP, is the rightful owner, respectively the guardian of these data files, the government wishes to avoid, at all cost, someone to petition a block against the exchange of these medical data. Let me be clear. There is a substantial advantage to an EMD, but the linked risks are very considerable. That a shared EMD is coming, nobody doubts it. But then preferably not in the way that our government currently envisions. The motive behind this talk, and I'm the last phase of my career a medical writer for a closed medical website, are the letters I receive from doctors, from GPs and specialists who are very concerned about this evolution. And these letters worry me. An additional reason is a broadcast program on Panorama, the VRT, recently, on the role of the so-called medical experts. Medical experts are, in fact, plain doctors, but doctors who work on the side for the insurance company. They can, on request, get access to your medical file. And this is very disturbing, because imagine you have a conflict with an insurance company. The medical expert, without telling you, can get access to your past, your present, and part of your future. That means that the insurance company always is the strongest party. So in the Panorama broadcast, the reporters and the interviewees argued that there should be a barrier, a firewall between healthcare and health insurance. And currently, this barrier doesn't exist. At the moment, all these illicit data and file consultations are still done in a manual way. But soon, electronic peeping becomes possible. And this is why it would be beneficial for the patient to receive a warning each time that his file, his medical file, is being requested or accessed, and that the ID of the peeper is communicated. This way, the peeping doctor can actually be called to account. I talked to the Minister of Health, Dr. Maggie de Blok, yesterday noon, and she agreed with me. But she said that working on the legal program to realize it would take at least a couple of years. So, do I exaggerate? I don't think so. Since October this year, almost 2 million Belgians consented in sharing their EMD. But my question is, do they realize what they consent to? This happens with every one of us who checks into an hospital. Automatically, you consent to share your EMD, except when you do not waive this right. And can we accept this? All ethical thinkers agree that the patient, and only he, is the rightful owner of his data and thus of his medical file. The doctor, and in extension the hospital, are the only gatekeepers or guardians at most. Doctors and hospitals alike who collaborate are in fault for this cooperation and taking part of this system. And this is something that young doctors should realize. This also implies that our government, in its unquenchable thirst for big data, does not have the right to demand to save or to use your private and personal data. And this raises very strong questions for the e-health project the way it is currently being developed. Another thing is that not only the doctors, but also private companies like health insurers or health funds, call them mutuels, start to encroach on your privacy. And in this case, vigilance is primordial. There is in our country a shadowy private organization called the Intermutualistische Agentschap. Nobody of the citizens knows about the IMA. But the IMA was established almost 20 years ago by the 7 health insurers or mutuels. And it gathers all the administrative data, such as sex, age, composition of the family, your address, but also the location and the kind of health care, kind of therapy, kind of medication you got. The IMA can easily reconstruct your past through the involved nomenclature numbers. It is in essence a data broker, a trader of your personal and private data. Data they sell to the government. A bank also owns a substantial amount of data, personal data, financial data of its customers, but it is completely forbidden to sell or to pass this on to a third party. Big data is big business. And not once has our government, by my knowledge, and I followed the government for 45 years now, the government has asked its citizens what their opinion is about all this. And it is not intending to do so. In the Netherlands, recently, a couple of weeks ago, this was done through a widespread questionnaire. More than 1,300 Dutch adults answered the question, and the result was impressively negative. Only 38% of the Dutch agree and indicated that they wouldn't mind that their data were accessed by health insurers. The majority, an overwhelming 45%, did not agree. And the higher the education of the interviewees, the more they resisted this tendency of the government. No, they said, we will not consent, we will rather manage our data ourselves. And what's more, they want to be able to befriend or defriend doctors who want to have access to their data. Just like on Facebook. The question is, who will be the first patient in our country who will file a complaint against the IMA? The IMA claims that the collected information is used to improve the treatment of the patient, and that the collecting data would be covered through the informed consent procedure. Informed consent, by the way, implies the right to revoke your consent. Did your insurance company, did your mutuelle ever ask you if you were informed about your consent? And did they ever ask you if you wanted to revoke this consent? I don't think so. By the way, the IMA as such makes use of the so-called opt-out formula. And that implies that anyone who does not refuse consents. Well, my friends, the European Commission has already warned Google for these kind of practices and strongly fines frequent offenders. I, in any case, have never given my informed consent, and I will not. I can assure you I'm definitely not a paranoid, and I believe that the government has the best intentions, but I don't believe in the best intentions of insurance companies. I am, however, very worried when I discover the way they use all this data in order to develop a so-called healthcare policy. I'm not against the use of IT for the development of that policy. I do, however, cower at the thought that a computer program, can conclusively decide what treatment would be the best for me, and that this conclusion is based on the so-called objective data. Because this computer decision, the way it goes now, is the sole, non-deniable, almost wholly answer to a disease. And don't you dare, as a doctor or a patient, dissent of that trajectory the government, the National Health Service, has designed for you. And this brings me to the last subject of this talk, the use of the so-called prediction models. It turns out, says Professor Karl Moons, I interviewed from the University of Utrecht, that these prediction models that we use in medicine are often not reliable. The supporting idea is to calculate how big the odds are for someone to become sick or to die. The models are based on the collected data of all our files. Prediction models are very sexy. And physicians are decreasingly treating based on clinical expertise and gut feeling. And that's a bad thing. And they are making rather increasing use of the so-called objective methods to calculate these odds. They use the so-called evidence-based medicine. Well, I must disappoint you. According to a survey ordered by the European Commission and realized by the University of Sheffield, only 11% of the so-called evidence-based medicine is really evidence-based. Unfortunately, the quality of most of the predictive models is not to write home about. As in case of the EBM, a significant amount of data is missing, and an excessive conclusion have been made. 60 to 70% of the predictive models University of Utrecht checked, and that can be found in most of the reviews used by the National Health Service, should never have been published in an academic literature or paper, say Karl Moos. This is shocking if one considers that predictive models are increasingly finding their way to the regulation, on the internet and also in apps. This field of study is still in its infancy. There is not a lot of general knowledge available. And I do not to have emphasized that bad predictive modeling can be significant consequences for patients. For an obese patient, the consequence might not be that harmful, but in the case of cancer, you have to be sure of the model's accuracy. The odds of a model are not definitive and are not law and order. There is always a degree of interpretation necessary and present. In the meantime, the medical corps is being imposed on one paper tiger after another. And in this process, the patient, all of us, is subdivided in different multiple pathologies, each with a different care trajectory. We already have 3 care trajectories now. For diabetes, for kidney failure, and for COPD. Soon there will be 4 more. And soon we will see patients, and the older they grow, like me, will fall into 6, 7, or 8 or more trajectories. At the consultation, imagine the doctor will ask for what trajectory the patient is coming in today. Even Kafka would lose his way in this process. In the journal Huisarts Nu, you all know, 2 unsuspecting authors, Professor van Pottelberg from Leuven and Professor van Rooyen from Antwerp, frankly argue that there is little scientific basis for the care trajectory. But the National Health Service maintains the trajectories. The new policy does not at all lead to more efficiency, transparency, or for choice options for patients. In contrary, healthcare professionals, just as GPs and pharmacists, increasingly feel that they have to enact increasingly a senseless policy, senseless for both patients and for society. In conclusion, I would like to cite the French writer and Dr. Filippo Monteleone from the University of Paris, who is the author of Patients, réveillez-vous. He claims that under the influence of economists and managers, we move past the essence of healthcare, and I agree with him. He says we have to change and distance ourselves from our fixation on digital data. The patient, ladies and gentlemen, is not an algorithm. August 24, 2 years ago, the Standard wrote that e-health offers government and health insurers, the mutuelles, their ultimate dream, an absolute control over the patient and his doctor. In the paper, one of the Leuven professors, Bart Preneel, cryptographer, stated that e-health is a secret society in our country, that nobody knows what they're up to, who they are, and that nobody knows who has access to the files. To conclude, a few weeks ago, in the plane back home, I read a very interesting article in the Financial Times. If the bankers in 2008 didn't believe in the naive way the algorithms they were confronted with, took the time for a cup of coffee, reflect on the data they were confronted with, then the financial crisis would not strike that heavy as it was. I appreciated that my doctor has his doubts. I appreciate it when he considers and thinks through his diagnosis and subsequently proposes a treatment. Good health is a bit like rock and roll. Good healthcare is a bit like rock and roll. It's about expertise, about technique, about self-expression, with imperfection, of course, but with authenticity and its life. It's like rock and roll, good healthcare, because it's all about experience and gut feeling. And with regard to The Economist, I like to paraphrase Virgil. Timeo Danaos et dona ferentes. For those under you who didn't study Latin or Greek, that means I also fear economists, even when they offer solutions. Thank you.